Sorry.
For the first unit exam. Anyway,
Bus.
so we talked about the drugs for cell wall that work as antibiotics targeting the cell wall, particularly beta lactam agents, including penicillin, cephalosporins, monodactams. They all have very similar actions in terms of how they work with the cell wall. However, they do have very different spectrums of activity. The next few agents we'll talk about also target the cell wall, but have slightly different mechanisms. We'll start with vancomycin. For those of you that will be working in patients, this is one of our go-to drugs for hospitalized patients, especially those who we suspect have some sort of staph involvement. This is a glycopeptide that prevents bonding of peptidoglycan strands in the bacterial cell wall. So again, targets the cell wall in specifically gram-positive bacteria. What's different here compared to penicillins is that it exhibits more time-dependent killing. And I'll talk about how that affects our dosing and our approach to treatment in a little bit. And again, the other key thing to recall here is that this is a drug that's reserved for gram-positive, typically severe gram-positive infections, including methicillin-resistant staph. It can also be used for methicillin-sensitive staph, particularly in those with a penicillin allergy. There is no cross-reactivity between vancomycin and the whole group of beta lactam. So it will definitely have a role there for penicillin allergy patients. And then there's a story around enterococcus. Generally speaking, vancomycin will be helpful for enterococcus, although there's a growing risk around what's called VRE, vancomycin-resistant enterococcus. When we speak of enterococcus, there's generally two main ones that are concerned for human infections: Enterococcus faecalis and Enterococcus faecium. The faecium species is typically more likely to have resistance to vancomycin, but we're also seeing increasing strains in certain centers around the faecalis resistance to faecalis strain. Helpful for mouth anaerobes, but we typically don't go to a big one like vancomycin for those infections. The other role for vanc for severe infections is given as IV. It's a systemic drug, although there is a role for an oral vancomycin, and that is for C. diff infection. So when given by mouth, vancomycin has virtually no oral absorption. C. diff, when that overgrows, that's a gut bacteria. So when you give vancomycin by mouth, it will exert local effects to treat C. diff infection. You'll recall C. diff is often a bug that grows out as a result of more broad-spectrum antibiotics clearing out the good flora. So when you treat someone with broad-spectrum antibiotics, you kill off a lot of the gut flora. It allows the C. diff to overgrow. And C. diff, I believe, excretes a toxin that can cause diarrhea. So, that becomes a problem when that overgrows. One of the strategies around managing C. diff, and there's a whole set of diagnostic issues to go. You have a person with diarrhea, you can test that for C. diff scores, etc. But once you do identify that C. diff, one of the things to do is give a course of oral vancomycin. So again, severe hospital-acquired infections where there's a concern for MRSA generally can be used for gram-positive infections, penicillin allergy patients, and then by mouth for C. diff. Key adverse effects to be aware of is the risk for renal toxicity can cause kidney injury. So if you're given an IV and the trough blood levels begin to trend upwards, that can be a sign, and also a risk factor for kidney injury. It can cause toxicity to the ear, ototoxicity. I think ototoxicity can be one of two things. Vestibular, which is, your ear, it helps regulate your balance and your perception of space. And then cochlear damage to the ear, of course, is responsible for hearing. Ototoxicity can be one or both of those presentations. With vancomycin, again, associated with high serum levels, but it can be reversible. And then the less severe issue is something called the red man syndrome. This is a reaction that comes from histamine release from using it too quickly, the IV vancomycin. Basically, what we do to manage that is to give a slower infusion rate. So again, no PO absorption, decent tissue penetration when given IV, actually get into the brain, prevents inflammation. It relies on the kidney for elimination, and as you can see, that half-life is fairly short. Healthy kidneys can increase up to 200 hours in stage renal disease. And it's not even fully removed by dialysis. So in your stage renal disease patients, it hangs around for a long time. Very often we give them one single dose and then just let it sit around. We monitor blood levels for vancomycin. We use TDM therapy, drug monitoring. It has a role. Let me explain. So there is the trough levels, which I mentioned, can correlate with some of the toxicity, in particular the ototoxicity and renal toxicity. So you want certainly to get above the MIC. Okay, antibiotic is not going to do much unless you get above the MIC. You do want to be above that for a good period of time because it is time dependent. But you do want that trough to come back down. Can't have it kind of remain elevated because the longer it's elevated, the greater risk you have to remain for the toxicity. So what we're looking for is a trough between 50 to 20 mics per mil. And we will monitor those trough blood levels when we are treating. That's kind of the traditional dosing, especially for meningitis, CNS infection, and stable healing. Kind of the more sophisticated dosing approach uses what's called Bayesian statistical modeling. Right. This is going to often be, in my experience, what I've seen is a lot of the EHR software kind of has this dosing software kind of built in. So it will pull from the patient's record their weight, their serum creatinine, and if they've gotten a loading dose or whatever in the past, all of that gets integrated. And it will use modeling so that it will then spit out a dose to you based on this individual's patient factors, what will give us a target AUC 24 in this range of 400 to 600. That is the picture. And that basically will give you the optimal exposure over time above the MIC. And by doing that, you get a lower risk of the kidney toxicity, etc. Now, what it's going to mean, I'll get to the question in a second. What is it going to mean for you guys as a prescriber? You have someone, septic patient, who you prescribe vancomycin. In an inpatient setting, typically you'll have a dosing service where pharmacists will be doing the dosing. But what's going to be needed in that, in order to do it, is those parameters. Typically, again, the patient's weight, renal function, and then whether they've gotten previous dosing in the past or blood levels. And then there is just really kind of advanced mathematical calculations that goes on in the software that will then spit out, okay, this person will get 750 Q12 hours and produce an AUC of 426. And that will be the dosing that will then be done. So really, a lot of that stuff is kind of done behind the scenes in the necessarily do those calculations.
So my question before you talk about the fact that versus vancomycin versus like penicillin, because I'm penicillin is also above kind of above the MIC2 threshold.
Right. So this is something of a hybrid. So there is the pure time-dependent killing, which you see, and I think Zosyn and other penicillins are a good example of that. Even there, though, you don't necessarily need to stay above the MIC 24 hours. Okay? Just the longer it is above the MIC, the more it's going to be. And the other extreme is pure concentration dependent killing, where you really want to just get it a high level, at least just once, and let the post antibiotic effect do its job. Here, though, Bank really kind of is something of a hybrid. You do want to extend that time above the MIC as long as possible, but you're really looking at this ratio, meaning the AUC MIC ratio. Again, it's getting into the weeds, and it uses a lot of this statistical modeling to really optimize the dosing. But yes, time above the MIC is important, but at the same time, you do get that level low so that you're protecting your kidneys, at least for part of that dosing. I don't want to get too much into the weeds because it gets confusing, but mechanistically, this is a time dependent on for patient tolerability reasons. It's important to spend time below the MIC, get those low drops. Some other drugs that are similar to vancomycin are the lipopeptides. So they also work on the similarly to vancomycin in that it exhibits cell wall. It's concentration dependent in terms of its activity, and agents in this class, teladancin, dalbavancin, veridancin. Similar coverage, gram-positive. This might give you some effects against VRE, where vancomycin would be ineffective. The main role that I've seen used for, particularly dalbavancin, is when you have someone either threatening to leave AMA, or you just want to give them a one-time infusion without necessarily admitting them from the ER. Basically allows you to give IV drug the long terminal half-life so that it does not require repeat dosing, at least in the patient setting. Dalbavancin has a long half-life, so that long elimination half-life gives it prolonged for, say you have a person that maybe, kind of a classic example of this would be an IV drug abuser that is not going to be a reliable patient by sign out with skin infection, whatever. And I've seen dalbavancin just be given an infusion. Here are the side effects. Telavancin is noted for nephrotoxicity. You can still get the red band syndrome with these agents. There are some effects on the kidney. But again, not one of our top line drugs, but for those of you working in PLR, especially if you're sitting patients where they might have the cell wall agents. Moving to the protein synthesis inhibitors, it's a group of drug classes that work to prevent bacteria from producing proteins necessary for its survival. And to review, basically protein synthesis takes place in a cell organelle, the ribosome. And with bacteria, we are exploring the difference between the prokaryotic ribosome, which appears in the left here. Prokaryotic ribosome has a mass of 70S. Basically, that S is a Svedberg unit. It's basically a measure of the size of the ribosome. That 70S is composed of 50S subunit and 30S subunit. That is contrasted with the human eukaryotic ribosome, which is 80S and has a 60 and a 40S subunit. So based on that, if you have a drug that inhibits ribosomal activity specifically at either a 30S or a 50S subunit, you know it's going to work just for the bacteria and not for the human rats. So that is kind of the big picture why protein synthesis inhibitors are effective in that, but do not inhibit human cell protein synthesis. With that being said, we'll start with the aminoglycosides. They include tobramycin, vancomycin, and casein. There are a few others that are used kind of more specifically, neomycin, etc. But these are the ones that you'll see most frequently in clinical practice. They work on the 30S subunit of the bacterial ribosome to interfere with the initiation of protein synthesis, and that ends up being a bactericidal effect. Tobra, gent, and amikacin, for the most part, are IV agents. There is an inhalation version of tobramycin that we give for cystic fibrosis. If you recall very briefly about this last semester, cystic fibrosis, one of the issues is that you have mucus buildup in the lungs, which is a site for colonization of bacteria, and tobramycin when given via nebulizer after that. Gent and Tobra also are available as eye drops and skin creams, but really in this context, we're talking about systemic treatment for IV use. They work pretty broadly, actually. They have very good gram-positive coverage against bacteriaceae. Pseudomonas, more so with amikacin than others. And Acinetobacter, which is another tougher gram-negative parasite. For gram-positive, this exerts synergy, particularly with beta-lactam agents. Remember, synergy is a concept where 1 + 1 = 3. You have two antibiotics that work okay by themselves, but are supercharged when you give them together. So, really, just a rule of thumb: most of your aminoglycoside usage will be synergy with the beta-lactam. And so it's working the cell wall, beta-lactam work with the ribosome together there. So your septic patients, those with other severe infections, UTIs, because of the way the aminoglycosides distribute, very often for kind of moderate to severe UTIs, you can actually use them by themselves, right? Like E. coli, UTIs that already, flow for themselves into it. Actually, the glycosides can create effective therapy. But again, really the big usage, I think, more so nowadays is synergistic with beta-lactams, gram-positive. And this is the kind of poster child for concentration dependent. So here we rely on high blood levels, at least the first part of the dosing interval, then a post They distribute well into your water. They're very hydrophilic. So again, that explains why they're very effective against antibiotics. Have to look at renal function for those indications. That's the main ramification. And the other reason, obviously, is the toxicity because it causes nephrals and phototoxicity. Yeah. Sorry, Professor. Thank you. Sorry about that. Okay, so we talked about vague, likewise causing nephrotoxicity and phototoxicity. Those are definitely the same issues that apply with aminoglycosides. I would argue that it's more of a concern with the aminoglycosides, particularly in when that accumulates in kidney disease. The ototoxicity also can be irreversible with aminoglycosides, so that's a concern as well. Neuromuscular blockade, we don't worry too much about unless they're on anesthesia. With the risk of vaccine anesthesia. So again, concentration dependent killing. We monitor very often both the peak and trough levels. The peak we want to be as high as possible, as tolerated, and then the trough, because of the kidney toxicity and post-antibiotic effect and all these other clinical benefits and the risks, we want the trough to be as low as possible. Janssen Tobra has the same potency, so we are targeting peaks of 4 to 6 for UTI. Again, the urine penetration is excellent, so lower targets here. For pneumonia, sepsis, it's intermediate, again, good penetration as well. And for most other indications, it's a little bit higher. Amikacin is somewhat less potent, so the levels are different. So an infusion of gentamicin will run typically for about 30 minutes. Within an hour, you will get the distribution phase, so you can get a sense of where the peak levels are. Okay, so 30 minute infusion, and then wait an hour, draw the blood to get the peak level. The trough level is best drawn right before the next dose of food. And with that variation, we want the peaks to be one of these targets, and trough really almost to be undetectable as far as the lower the better. Traditional dosing basically states that, oh, this is a short half-life agent. We need to give it multiple times a day so that there is some amount of it in the body. That is shown here. So if this x-axis represents a 24-hour period, this is a person with normal kidney function. Traditional dosing would give an amount of. Sorry, it's not that. There's other selected appropriately, but traditional dosing regimen would give it Q8 hours. And you get your peaks and you get your troughs in between. However, knowing what we do now about, again, the benefits of high peaks and post-antibiotic effect, low troughs, for patients with normal kidneys, we are able to exploit that using single daily dosing of aminoglycosides, which amounts to more drug being given, less food. So here, a once daily aminoglycoside regimen would get involved in infusion at time zero, maybe double or even triple the dose that you would give otherwise. Get that high peak within an hour of stopping the infusion. And then as your kidneys clear it, blood levels go down. But because of the post-antibiotic effect, it's bactericidal activity will continue throughout the dose. There is an original yes, there is. Okay. So basically, with moderate to severe renal insufficiency, get clearance less than 30. If you're using it for synergy for gram-positive, we don't need as much. So lower doses are appropriate there. You don't necessarily need to blast it like a high once daily regimen. And then pregnancy, cystic fibrosis, and ascites, they feel are not as well supported with once daily dosing. I don't want you to necessarily have to memorize all that. You know, once you're in practice, you'll have infectious disease consultants that will help you with that. But just kind of in the broad strokes of it, you know, just understand the justification for once daily dosing versus multiple daily dosing. Particular, as good or even arguably superior efficacy because you have higher levels, and the safety because you're giving less frequency and less frequently, allowing for those low troughs to protect the kidneys for years.
Dr. Val, can you hear me?
Yes.
Oh, awesome. So just from a clinical perspective, and this is for all the students, if, let's say you draw that trough level right before the next dosing, and your trough level is higher, maybe even significantly higher than what you anticipate. From the recommendation then would be to delay the next dose?
Absolutely. So if you have you know, either a lab or a really astute nurse, they will report back saying, okay, this trough is 3 or 4, and we're really looking for it to be 1. And yeah, typically the provider would still have to prompt, say, listen, hold the next dose. But yeah, clinically, the right thing to do there is to prevent it from accumulating. And the accumulation comes from when you are repeating dosing despite having, you know, higher than desired trough. So yes, you're going to delay the next dose. The amount given may not necessarily need to be adjusted, but the dosing interval might need to then go out to say 36 hours or whatever the case may be. And that will give it more time to drop.
Thank you so much for making it so clinical for them.
That's my job. Okay, so here is again the graphical representation of that. Don't dwell on the specific numbers, but you know, just the comparison between what a once daily regimen looks like versus your traditional dosing. All right, next group of protein synthesis agents are the macrolides. That would be erythromycin and its friends chlorithro and azithromycin. These work as a 50S subunit that blocks the bonding between amino acids and peptides that are being built in the ribosome. These also are, you know, fairly broad. They cover gram-positives. Here is where we really begin to reliably see some good coverage against atypicals. That's your mycoplasma, chlamydia, and legionella. So that's an important thing. Recall that erythromycin is part of our H. pylori regimens for peptic ulcer disease. And we will use chlorithro and azithro a lot for respiratory infections. Your familiar Z-Paks for azithromycin, for example. And chlorithro is great for smokers that colonize H-flu for bronchitis. So, you know, they definitely have lots of roles, especially for community-based infections. Erythromycin also, outside of its use in infectious diseases, has prokinetic effects in the GI tract. All right, so for macrolides, erythromycin does require some renal dose adjustment. You might go from PIDs to once daily dosing, but generally speaking, really not a lot that we're so concerned about. It's not a narrow per se. The erythromycin is kind of unique. It's really nasty on the GI tract. Again, it has some prokinetic effects in the bowels, so cause diarrhea. Some people may have allergic reactions to it, hepatitis, cardiac arrhythmias. The other thing with macrolides, you'll read in the labeling, erythro and chlorithro are very potent inhibitors of 3A4 enzyme in the liver. 3A4 is probably one of the most important enzymes in terms of drug metabolism. And drugs that are given currently with erythromycin or erythromycin will see their levels go up. Okay, now a lot of times drug interactions, especially for chronic drugs, two drugs that we know they're going to be taken indefinitely, kind of have those interactions baked in, and the drug doses are considered. But say you have someone that takes phenytoin for seizures. Now therapeutic and this drug 3A4 substrate. They are doing just fine on that dilantin until they develop bronchitis and all right, that's only going to be a 10-day course, but in that 10 days, that 3A4 inhibition could be enough to put them into phenytoin. So this is a real thing with drug interactions around macrolides. Fortunately, azithromycin has a much lower incidence of 3A4 inhibition. Pretty much, it's not to the point where it's not even clinically relevant compared to the erythro and chlorithro. So azithromycin would be the best bet. You don't have to really drug interactions, although their spectrum is not completely the same, but you might be able to switch to a series of one study. Chlorithro also has an issue around taste perversion. If you ever take it, it's this metal taste. It's not fun. Some LFT issues, it's a mess. But generally speaking, these are pretty safe drugs that we rely on. Arguably, they overuse these, but they're for respiratory infections and particularly maintenance. In terms of ribosomal agents, tetracyclines, they work on the 30S subunit to block RNA binding there. The synergy and recycling, the prototype drug is tetracycline itself, but that is literally no longer on the market. The ones we use most frequently nowadays are doxycycline and minocycline. Sarecycline is used mostly for dermatology. Or again, broader spectrum coverage, gets your atypicals, spider sheets, even some of the tougher gram negatives like Acetobacter and multi-drug resistant Acetobacter. Doxy and minocycline, you'll see a lot for acne, just as the daily prophylaxis for that, low doses. More treatment dosing for conditions like acquired pneumonia, particularly those with penicillin allergy. And again, they are helpful for certain STDs, that's something that we take. And some of the triple regimens for I think also disease. They do though have some side effect baggage. They, we use them for skin infections. One of the ironies around it though is that it can cause photosensitivity, meaning that your skin becomes more sensitive to sunlight. They want to go into sunburn and that's doors. Allergic reactions in eosinophilia, systemic symptoms, esophageal irritations get reported, so tooth discoloration, inside things further go, and they have some effect on bone growth and transfer cross milk, so you avoid using children. Right? So, you know, not the least safest food drugs, but you'll still see patients on these chronically, especially the derm implications. They are involved with chelation reactions. We would call these are like antacids, like calcium, magnesium, polyvalent. Calcium, for example, carries a 2+ charge, magnesium also a 2+ charge. They will bind to the tetracyclines and complex it to the point where it's unabsorbable. So you have to separate higher data products and acids from the tetracyclines. Related to those are titracycline, which is a glycerol cycling agent. Again, works on the 30th subunit. Titracycline, though, is an IV drug. It's used more for severe systemic infections, particularly those with, say, multi-drug resistant organisms, GI infections, etc. Again, as with many of the other tetracyclines, very broad coverage and positives and negatives and extended spectrum data, producers, acidic factors, does not get supervised. So you'll see this used in the hospital setting. There's actually a black box warning about increased risk of mortality. So again, we are not using this to agents with severe medical infections. It's not for sepsis or infection. It's really more tissue. Clindamycin works on the S subunit for gram-positive infections and anaerobes. Kind of the thing about this, we think of this as mouth anaerobes, not so much the GI. Strictly gram-positive coverage. We will use Clinda a lot for patients with penicillin allergy, either in surgical prophylaxis or local treatment. And it can be reserved also for very severe it's really bad skin infections. Clinda is not the greatest drug as far as tolerability as well, because it's diarrhea. Finally, this group, oxazole, these are another agent that works on the bacterial ribosome. Really, its use is for MRSA and ERE. Really think of this as an alternative to antibiotics. Very often in the hospital, these patients will have an IV bank and then additional treatment with service charge. Give the nasal because it's available for but you can also start them on IV the nasal as well. Again, MRSA, VRE are doses than one of these drugs that we kind of strict. It's not personal, but very highly effective. Once you want to switch one. And it has this property of monoamine oxidase inhibition. This interaction with cisoronics that can cause serotonin syndrome and inhibit with oxidase inhibitors. This probably is a little overplayed, although again, there are published cases where this effect is a real thing. Unfortunately, we don't always know in advance that a person on antidepressants that needs to put on the nasal. Typically, that you do that, it's to stop it. So there are a lot of cases where people are treated through it, but ideally. So those are the ribosomal agents.
Good question.
Mhm.
So since there are no renal dosing documents, and I know, yeah, because often the linezolid is always used, it's often used in outpatient commercial therapy. Do we use it in the hospital more so in renal insufficiency patients because of you don't have to?
Yeah, vancomycin gets challenging sometimes in renal patients. I mean, not the worst thing in the world. Sometimes even your dialysis patients, you can give vanc and just, give them 1 gram and just have it sit around in their body for a while. Because the thinking there is their kidneys are already shot, so you're not worried about renal toxicity per se. And the fact that it's time dependent, so even if it kind of lingers in the body for a long period of time, it's doing its best work there. But still, the alternative to that would be linezolid. You may use it in your dialysis patients without worrying about it, kind of lingering around. The concern there would be that in the first example, the vancomycin case, that if it's in the circulation for a long period of time, it can then develop resistance and that sort of thing. So linezolid kind of avoids that. It's in and out. Even in safe drinking. So yeah, we do use inpatient IV linezolid or even oral linezolid and step down. Right, next group of drugs work on DNA synthesis. The fluoroquinolones and metronidazole. Fluoroquinolones are agents that work on DNA topoisomerase. This is an enzyme that unwinds the double strand of DNA, then allows it to be unzippered for replication. You'll recall in the oncology unit, there are a few classes of drugs that also work as kind of blockers of topotecan. Here we're talking about DNA, bacterial DNA. Quinolones exert bactericidal activity and kind of a hybrid between concentration dependent killing with long post antibiotic. You'll recognize these drugs by the fluoxetine, their generic names, ciprofloxacin, levofloxacin, oxy, and velofloxacin. These are important drugs. They have pretty broad spectrum coverage. Some of you may be old enough to remember there was an anthrax scare with dust in the envelopes, right? And health departments were stockpiling Cipro because that was one of the few drugs that can deal with the anthrax pandemic. So, they do have some importance there. The other side of it, though, is that resistance to fluoroquinolones have been developing. pretty significantly over the years, so we really have to balance that against the overuse. But with that being said, they are helpful for a number of infections, gram negatives, including Pseudomonas, strep, methicillin sensitive staph. MRSA tends to confer some resistance to adult ones. They help for atypicals, and Moxie is good for anaerobes. It used to be that we use these pretty regularly for community-acquired pneumonia. It's cranked that down a little bit, but it still can be helpful for that. Aspiration pneumonia, because of the anaerobes that are usually implicated, lots of sensible there. UTI, Cipro, yes, weight levels in the urinary tract, but again, if it's an uncomplicated UTI, we could usually use some other agents there. Anthrax is one of the key issues where it is important and it can be used, but it's not every day you're seeing patients with anthrax, so, but it's good to know it's out there. Drug-resistant TB. We covered tuberculosis in a couple of weeks. This is one of the strategies for that. And then certain enteric infections, Salmonella, Shigella, Campylobacter. In addition to the resistance concerns, there are also, a number of side effects. Again, most patients don't get these, but there's enough there for, again, to be a concern. GI upset, C. diff diarrhea, if they're on all courses, IV. They readily get into the brain and can kind of increase the activity of GABA, inhibitory neurotransmitter in the brain. So, as such, it can cause some issues, headache, dizziness, seizures, I think before as well. It can interfere with the blood sugars, hypoglycemia, photosensitivity. It also, very notably and very uniquely, have some problems in terms of tendon issues, particularly in young children or even in older patients with long-term exposure. It can there have been a number of patients that developed Achilles tendon, which is a pretty significant issue after kind of working for several months next to Aaron Rodgers. Surgery available to you, but those issues are notable for clinical and the reason why we avoid certain patient populations and could cause and a lot of kind of unique side effects. Children should be using another class of drugs that are subject to the chelation effects of calcium. Increased dosing of the usually close to once a week. Again, resistance is the key issue here. Very often bacteria will learn through that topoisomerase enzyme, which is a target for syndrome, and will alter it so that the antibiotic doesn't stick to that enzyme so much. We've seen also influx pumps. So a number of different resistance mechanisms. Bacteria. We said that clindamycin is good for mouth allergies, flagyl is good for your GI. So the role of the GI tract, but it's where it irritates aerobic activity. You use this for C. diff. And then we'll cover, parasites and flagyl is one feel under the drug that you've ever taken is before. It gives you an acid that does have disulfur and the problem. So. So for C. diff so far, we talked about oral vancomycin and then metronidazole is our second. C. diff, another. That's eight. Eight ones. Or activation tool. Really, this is the antibiotic version. Sulfamethoxazole works really upstream to inhibit the production of the folate precursor, and it's like the inside catalyzes the plants. So they're formulated together. You can actually get standalone trimethoprim. But really the overwhelming usage is of the combination product, which is a fixed dose combination, trimethoprim sulfamethoxazole, and it will be given as either orally, Bactrim, SS, Bactrim, yes, single strength. Fairly broad spectrum. You get your gram positives, including MRSA. Some extended spectrum, but gram negatives, one of our drugs of choice for like E-coli, and other less severe gram negatives. But when it comes to, say, standard troponosis or something really, really nasty gram negatives, Bactrim might be one of our only options for those as well. But not really against you know, the complicated PIs, those without self-allergy, that could be your places, and the rest of the infections, again, self-allergy is weeks, HIV, infections, but this is one of our key drugs we use for. Yeah, and self-allergies and contraindication. It can cause acute interstitial nephritis. Also, in the third trimester of pregnancy, because of those development. But one other thing I don't have listed here, but I could tell from my NF1 experience on Bactrim, it can also cause hypoglycemia. We talked about diabetes drugs a little bit later in the semester, but one class of drugs that used to treat diabetes are also sulfonamides. They're sulfonylureas. basically work to increase insulin secretion. Sulfamethoxazole shares some structural similarities to those agents, and as such can increase your insulin secretion, causing a drop in your blood sugars. And not to get too much into my first medical history, but I had a nasty infection of prostatitis, which is a complicated UTI basically, and I did not tolerate this action from the blood sugar count. So that is a risk. So if you have patients that complain of, kind of being lightheaded or hungry or have symptoms of hypoglycemia, that so that's another drug that interacts significantly with warfarin. Couple others that are more miscellaneous. Getting there, guys. Daptomycin, another inpatient drug we use for severe infections, including MRSA and PRE. Usually, you will have your infectious disease consultant on board before you start that bill. But you're thinking here, complicated skin infection, joint endocarditis. It does not help though for pneumonia because it can find pulmonary infections. Basically, doesn't help the situation. Break it out to the market. Can be used for multiple resistant infections, gram negatives. Really not much to say here. We don't see this too frequently. Certainly, my experience, not one of the widely used classes. And then two other groups I just want to highlight for being selected for types of infections, particularly GI antibiotics and UTI antibiotics. We'll start with the GI agents. Fidaxomicin is a drug specifically for C. diff in the GI tract. So this is our third C. diff drug. Store, oral bank, metronidazole, and now fidaxomicin for a C. diff. So again, C. diff is typically a secondary infection after C. diff overgrows when you give off your gut. Again, it's a more expensive alternative to PO bank. That's the one that you'll need most frequently. It works just in the GI tract, so not surprisingly, because of budget vomiting, and it does not have systemic effects. And then rifaximin is another GI antibiotic here. It's more for travelers, diarrhea, E. coli. You may recall we talked about irritable bowel disease last semester, and rifaximin was one of these gut antibiotics that's useful for that as well. Maybe see some of the details. It's again not systemic infections. And then the non-systemic UTI antibiotics, there are two that are worth highlighting. One is fosfomycin. Gets at most of the common UTI bugs, including E. coli, staph, Klebsiella, Proteus. Those are common UTI bugs. It's given by mouth and then concentrates in the urinary. Let's help with that. And then nitrofurantone. Much older drug we use for UTIs. Again, covers a lot of the common UTI bugs, but for a number of reasons, not one of our top choice agents. It causes pulmonary fibrosis, and really can accumulate those with even like moderate to severe renal insufficiency. This drug, if you recall, we talked about last semester, the beer to this, the drug can quite avoid in the elderly. Nitroglycerin is center on that list. So, really for a number of reasons, this is only going to be really for your young, healthy adult women with kind of routine complicated UTIs that you can give 5 days of stuff. You don't want to get too long, accumulation. You don't want to get not feeling too well. That makes sense out of all this stuff. A few cases, right? I this all together. Start with an 86-year-old female nursing home resident. She has confusion and disorientation that's worsened from her baseline. Your analysis is positive for nitrate and leukocyte esterase. Well, why would you get a urinalysis if you have a person with confusion and disorientation in the nursing home? Okay. So yeah, it's one of the main issues. Mental status changes in the elderly, always try to rule out infection. And in fact, what makes it a little trickier is that they don't always spike a fever, right? So really, to be a good clinician, if you're doing nursing home consulting, definitely get a UTI and issues with mental status changes, especially the nursing home. Anyway, it's positive for nitrite and leukocyte esterase. Those are both suggestive of bacteria in the urinary tract. It's negative for epithelial cells, which is also actually a positive finding for the UTI, right? Epithelial cells usually and skin. And she has a history of sulfur allergy. So that's the case. You get back culture results 24 hours later. It identifies the bug as E. coli, greater than 100,000 CFUs. And then your sensitivity report is as listed there. Lab, sensitive, ampicillin, spasm, 17 is actually resistant, Cipro is resistant, sensitive to gens, independent, resistant to resistant, sensitive to openness, resistant to that. So, E. coli, we said often one of our top options is Bactrim, right? I would argue there's 2 reasons why we would get that in this case.
Just prevention.
Resistance Bactrim and so Bactrim, right off the top, we can eliminate. Some of these other resistance patterns here, Cipro resistance, and we're seeing that increasing in the community. Really kind of rules out our clinical group. Jet and Cobra, okay, it maintains its sensitivity there, but these are IV only. You don't necessarily have to give IV in this case. So Jet and Cobra is nice to know if it's if this progresses, and you have various other. If you really get to look sick, other than just the status changes and urinary symptoms, then definitely Genticobra is a good option. So what does that leave us with? Nitrofurantoin, let's look at that. It's sensitive there. Is that a good option?
No, not really.
All right, what do we say about nitrofurantoin?
Here's criteria.
Yeah, there's criteria as well. We don't want to give it any help. So although it's sensitive, it might do more harm than good, even in this patient. So really, if you are looking at oral treatment, that just leaves us with amoxicillin. Okay.
Is there anything with the imipenem?
Independent broad spectrum agent, IV only, probably would not use that first. Now, if this person gets hospitalized, presents with no status change, they look sick, independent might be what we use.
Before you get the culture.
Just for a day or two, if we get this culture back, we are de-escalating right away to either IV unison or oral.
Thank you.
Any other questions? Yes.
And if you guess where you switch from an empiric antibiotic regimen to a more specific one, do you have to like do the complete, I assume you have to do the complete course of the second regimen as well? Or can you?
Yeah, what we usually do is count the days. So if we are treating, say, a complicated UTI that requires 7 days, and we started them for 2 days on the broad spectrum, we would then go 5 for the rest. So we add the days. The question is, why can't we use Monoral? It just wasn't on our, sometimes sensitivity reports don't report everything. That is an option. It's an oral drug for UTIs, and does not carry a lot of the issues that the so I would say that that's an option. Just in the particular report. It happens to be more expensive. Okay, great. All right. Case 2. 54-year-old male. He has a history of gallstones, and he's scheduled for elective cholecystectomy. You guys are going to be his pre-op PAs, and the question is antibiotic therapy included as part of his pre-op? The elective gallstones or elective cholecystectomy are generally going to be able to do it fairly cleanly. It's a laparoscopic procedure, so the incision is minimal, and most of the surgeons will be okay if they are not prophylaxed. Both pre-op and post-op. Pre-op, basically, prophylaxis is for more kind of dirtier procedures, or it's a bigger incision. And then post-op, you will, if it's some sort of instrument being put in, like hip or something, like you might give it a post-op prophylaxis. But generally, that fully elective, uncomplicated, they can get away with not pre-op prophylaxis. If they are pre-op prophylaxis, probably cefazolin is your top choice. And if you're allergic to penicillin, we're either going for vancomycin or clindamycin. Again, make sure one of the objectives is to kind of know around the issues around penicillin. So that's going to be those alternatives get some clarification. Any other questions? Next up, you have a 7-year-old girl. It's being treated with amoxicillin for otitis media. She's had those symptoms for 3 days. After the first dose, girl's mom notices swelling of the child's lips and mild difficulty breathing. She's seen in the emergency room, and at that point, they declare that she has a penicillin. Pediatric patients, you might not have a history of allergy, and in this case, probably maybe the first exposure penicillin. She gets that reaction. If it is a true penicillin allergy or mild infection such as this, you don't want to reach out. Okay. You would consider alternatives. What do we say are appropriate alternatives for penicillin? Any other beta-lactam agents are appropriate? They look to you consider rolling the dice for, say, an oral, second and third generation cephalosporin, which has a fairly low cross-reactivity, penicillins. Something to consider. Something with kids is that we're not going to do a lot with Cipro or tetracyclines because they have problems in kind of developing body with bone toxicity, the soft tissue issues around tendons, ligaments, things like that. So we're not going that route in 70. We can consider Izipro, Isaac. That's an active body. You have the pediatric dosing plan. That or not too controversial, but we can actually just decide, okay, we don't need to treat it. There is actually very high spontaneous remission for legacy. So I'm not going to always like that, but again, you know, it's one of those things that you can actually treat symptomatically, and very often most cases will resolve.
Way back because of obviously possible. That has like a one brand.
Yeah, all right, so Monobactam, as treating. It's IV only for one, and we're not gonna do that, but, generally speaking, that is for severe gram negatives that have a penicillin allergy, you can feel safe prescribing as treated. Because it does not have cross reactivity. It's not going to apply in this case without paper idea, media, but more broadly, to address your question, yes, that is considered pretty much a go-to agent for gram-negative infection. You can feel pretty confident describing that it's patients, if they happen to have a reaction to that, it's not going to necessarily be from the same underlying mechanism. Our final case, this part. We have a 56-year-old, he has developed community-acquired skin infection that is shown to be methicillin-resistant staph aureus. Again, this would be probably outpatient treatment. MRSA means any beta-lactams. So, you know, we often give in this case, first generation stuff. But being that it's MRSA, we do see some community acquired MRSA skin infections. What are the alternatives here?
Linazolone.
The nasal you can give orally. Something of a big gun, but it's certainly an option. I would go not tigecycline, one of the doxycyclines. That those are great drugs for skin infections that may be sensitive to MRSA. So again, this is an outpatient treatment, so we're having to go into the IV. So what you'll be confronted with on the exam, and I still got to work out the logistics of it, but it's you will have basically a list of drugs outlined by pharmacologic class. So your immunopenicillins, your extended spectrum anesthetic, first generation, second, third. Basically a list of their generic names and brand names. mission that you'll have is, basically, if there is a drug, question about selecting the best treatment. You know, it's not gonna be maybe necessarily a matter of remembering drug names and classes, have that as a reference. But again, kind of knowing in your mind what categories of drugs are for certain conditions. I will transition into the review material if that's okay. So, over the course of the last couple of weeks, I have gotten a number of really good questions by email. That shows that you've really been thinking on the material. I hope that some of the responses that I've provided to the individual students are helpful. And likewise, I'd like to see if I could share that with the rest of the class. So, you know, I had a student ask about, how a lot of these antibiotics have overlapping spectrum, which is a feature and not a bug. The idea here is that, again, thinking back to the transition between empiric therapy to more targeted therapy. We would go with broader spectrum antibiotics that can cover multiple bugs initially, until we're able to better identify the source of the infection and the implicated bacteria. At that point, we would use more targeted treatment. So the better way to think of it is not that, okay, you have all these drugs that cover, you have kind of conceptualize it as broader spectrum agents that cover a wide variety of bugs. And then those are used more initially, short term, and then you go to narrower spectrum. Very often, again, you will be divided with clinical practice, and even on the exam, there's something like we did in that first case where you have a listing of options. Obviously, the resistant ones you know what the ones to select, and then if there are contraindications, I always say this, but on multiple choice exam, there will always be one best answer. The practice, obviously, multiple things that are perfectly good, which doesn't like, but on an exam, my job is to make sure that it's the best answer. So we avoid really controversial questions. So really, that is the best way to kind of think of these drugs kind of overlapping spectrums. The allergy issue is another thing that classmates asked about. And again, I think when it comes to self-allergy, it's pretty straightforward. We avoid backdrop patients. Penicillin allergy is a little bit more nuanced. Penicillin allergy typically will mean that, you know, if it's documented as a penicillin allergy, we avoid all other penicillins altogether. Technically, we might have someone that has a reaction to some backdrop, so tolerate dosing, we don't always challenge that. But as we move from penicillins to first, second, third generation penicillins, those carbapenems, as you go through that spectrum, you get less and less cross sensitivity to penicillins. If you have to give, say, ceftriaxone, someone with a severe gram-negative infection, a history of, say, mild to moderate penicillin allergy, your clinical decision making may dictate that person gets ceftriaxone. The risk of cross sensitivity in those cases, probably less than 3%. So that's kind of the level I want you to know it at. I mean, we talked about the side chains and went into the chemistry there, kind of asking about side chains. Granular level. We've never seen anything, right, anything with chemical structures on the advances. So that's kind of the idea that you have there. And then, of course, we talked about it a little bit on the street. This being one beta lactate and the load should be 0 plus 50. Yes, repeat that again. That's street. On the back, that's the one that's 0 or close to 0 plus 50. Were there any other questions that you've had as you've got over antibiotics? Yes. Yes.
Still not really certain what is the role of the kind of therapy. It's dangerous.
All right, that basically is going to be one of those agents where it's reserved for severe infections. Usually with kind of some of the tougher gram negatives and positive. Again, you end up either with a bug that's specifically sensitive to it, or a patient who might have a history of multiple allergic reactions. So, you know, someone comes in, either a fever of an allergic or a septic, and they're eliminating some of the other options. In a lot of centers, a lot of hospitals, it will be considered a restricted antibiotic, meaning that we will have it like specialists. Some centers, it's right, but that have to do with again, not something we use routine. Both because it's so. Yeah, if they have like, if they're going to get a severe systemic infections, not necessarily bloodborne because of how it distributes and relative tissues and such, but severe systemic infections. But yeah, it's really going to be end up for most cases being reserved for. Yeah. That's right. Basically, when you take it by now, you'll have local effects. So, before it gets, you know, goes into the bloodstream, guest has it designed to the ICAP to get some issues with that. So, that's more of a local TDA. All right, so 4 lectures that will be covered on oncology side for exam 1, pain, NSAIDs, opioids, neuropathic pain drugs, oncology, post-antibiotics. I would like to start with a review of the pain lecture. Again, Mr. Chance, if you have specific questions, but I frequently asked to provide a review of the opioid conversion. Hearing no questions, we'll move into this opioid conversion example. Patient-controlled analgesia, remember what that is? Basically, that's a mechanism for delivering IV opioids through a pump. As a provider, you will order it with certain parameters. And in this case, you have a post-op patient that gets a basal at 0.5 milligrams an ounce. Can someone tell me what that means? Every hour you get 0.5. Okay, so that is just a steady infusion, half a milligram an hour. So regardless of what the patient does, they are getting that amount of morphine delivered. As long as that order is good. Right, so that's the basal rate. And then it says bolus 1 milligram. What is that?
Oh, sure. How much is it in there?
So that is the amount that gets delivered to the patient on request when they hit that button on their PCA. That's 1 milligram that goes in immediately upon activating that pump. In addition to the basal. And then you have lockout 6 minutes. What is that?
I have to wait if I want to first and get another dose.
So that is the amount of time in between which a patient cannot request a second bolus dose. So they get a bolus at 1 milligram. It starts to fall on the pump, where they are not allowed to get any more until that lockout is over. In this case, again, it's 6 minutes. They're still receiving the basal, and that is just going to be there always. But the lockout means they cannot get the bolus. That's 6 minutes. 6 minutes of C. Right. So that is the order. And then it says, and by the way, this is a real question. And as I look at it, I feel kind of sinister and cool asking it this way. But you know. Anyway, they bolus themselves 16 times in the last 48 hours. Now you're ready to discharge them from the hospital. Obviously, they can't take a PCA home. And at that point, they developed enough kind of opioid tolerance where you're comfortable giving a fentanyl patch. Fentanyl patches, by the way, transdermal, good for 72 hours, and you only give it if they have some tolerance. You're not going to just put someone on a fentanyl. Okay. But here it's appropriate. They've been on their post-op, they've been on opioids for a while. Now you want to convert them from IV PCA morphine to fentanyl. So they're changing drugs, they're changing lung administration. And the question obviously is, what is the best strength and tension of fentanyl provides to this patient? That's the other thing. You have to be conscious of what is commercially available. Okay. So you might get a response of 32.3 milligrams. Again, it won't be a choice that multiple choices there, but the reality is that you also have to kind of adjust for what's commercially available. In the case of fentanyl, it comes in 12, 25, 50, 75, 100, and it might be some higher strengths. But basically, those are the strengths that it's available. And then the patches are basically good for 72 hours, 3 days. Okay. So, what's the first step? Yes.
I'm sorry, I might have missed this, but that conversion, 7.2 milligrams per day IV, blah, blah, blah. Was that given in the question?
This will be given, absolutely. Okay, so. Yeah, so there are references, you can always look up. Okay, the opioid conversion table, okay, go online or whatever. On an actual exam, I will give you the conversion factor that's relevant. Okay, you will not be asked to memorize that entire table. And. So yes, that was given on this actual exam. And those are, this is verbatim, the question. That was- Okay. So the question, obviously, is a multi-step. Did you want to say what the first step was?
I had a
Oh,
question.
you had a question. Go ahead.
About it being over 48 hours and it with a 6-minute lockout. How do you know that right after the operation, the patient didn't go through 15 of their boluses? And then the second day, not have any?
That's a good question. That's valid. So I guess you are assuming that there was a progression in their pain so that maybe the second day they didn't need it as much as the first day. That is possible.
You might not even need it.
They might, yeah. So the thinking is if you kind of average it out over the 2 days, then when you discharge them, you might be overestimating their need. As a clinician, and that's a very smart thing to think about. You may want to get more granular in how those bolus doses were administered. Like you said, is it 8 times a day 1, 8 times a day 2, or like you said, 15 times a day 1, a day 2. That's just valid. You're given, this is the information they get. Yes. So what you're saying, the first step is to figure out how much they've done, right? Okay. So if you want to look at the 48-hour interval, right? $16 bolus doses in 48 hours times 1 million. But you also have to figure in the basal dose, right? Basal is 0.5 milligrams an hour times what?
48 times 48.
48 hours. We went to so far. Okay. Now this represents 16 plus 24. $40 milligrams over how many days?
2.
Okay. Which is 20 milligrams. And that is how much morphine was delivered, average over the 2 days that they got, the last 2 days of PCA. So once you have the daily dose of morphine, the question then is, how do we convert it to fentanyl? On the exam soft, you will have the option to use like the built-in calculator. So you don't have to do all the math yet. But we know here that 7.2 milligrams per day of morphine, 6 micrograms per hour of fentanyl. On the right side, we have 20 per day. Are you with me so far? This is kind of, like cross multiplication. Sixth grade math. So, here what we would do is kind of like a cross multiplication, so 20 times 6.
Don't you have to convert your units though? Yeah. Don't you have to convert the units though? Just hours and days.
Oops, did I have
This one's in micrograms.
Yeah, they're the same, they're the same. So here, fentanyl is kind of weird. It's measured in micrograms per hour via this transdermal system. If we just go with the IV to transdermal, using that, equation I gave you, you should be okay. Right? Because ultimately what we want is also in micrograms per hour. When I circled that, I didn't mean to, assume that that's the right, just saying, in units. So if my math is correct, I'm coming up with 16.6. Now 16.6 is squarely between A and B, but we also have to do what? All right, so we do a conversion to reduce that number based on the cost comments. When we go from one opioid to another, the second one ends up being slightly more potent just because it's a different chemical. Your body's tolerance has to be the same. In that case, the fudge factor there can be a reduction anywhere between say like 40%, give or take. If we do that, we end up coming very close to 12 nights per. So this might be a little tougher than the average opioid conversion because we're dealing with fentanyl. But what made it not as bad is that it was already starting with morphine, so we're not doing that intermediate step converting to morphine. So, but I would say this is maybe an 8 out of 10. Being a tough question, but best to kind of practice with this so that you can see a real life. Yes.
Why did you say you reduce it from 40%?
Okay, so that is kind of, it's called the fudge factor, it's used to account for the cost of. So, yes, pharmacologically in vitro, 7.2 milligrams of morphine will be about 6 mites per hour fentanyl.
Yeah, it's not 75.
But in the human body, once you've gotten a certain amount of tolerance to one particular chemical,
So isn't it 16.6?
switching over
16.6.
uh,
I mean,
it's a little bit more into the point where it will interact with the receptors and make it look a little bit more potent than it should be.
50%.
Really, that's my best way of explaining it. If there is, that makes the second drug, slightly more potent than it would be otherwise in relatively the first drug. So they keep that.
Oh, you guys.
Now, over time,
16.6
as the patient develops.
and minus that
That
from
second drug might
16.6, right?
Because they develop tolerance. But when you're doing that
It's
first
not
version,
anywhere near 25.
Okay, so then for the advantage, we're not looking for the exact.
That makes more sense.
That's
Mhm.
Yeah, exactly. So if you will take what is the closest of the options
That was
you guys commercially available. Right, so again, it might come out with something with 0.3333 at the end or whatever. On a multiple choice exam, you'll get only options based on what's commercially available. Likewise, so you'll be choosing from what's the closest.
Always assuming.
Well, it's a range. 40% is what I like to use because it's in the middle.
Okay.
So to be a little higher. The question is. Yeah, they cross, I mean, it's not a number in, that you can predict based on just looking at some. It's a range. It's basically, some amount, around 40%. It's the difference between the in vivo cross tolerance and what's observed in vitro observed. So a good, I would call it a rule of thumb to use 0.4. You'll see some examples which they use 0.5 and then it'll bounce up a little bit more. So really, there's not one specific hard and fast rule to do it. My preference is to use 0.4.
For me, just one was fine. For the first step, so you're multiplying it or like figuring out the total amount that they actually used, not the total amount that they could have received? Okay, that's right.
So I can ask you separately, if these are the PCA orders, what is the maximum amount that they receive? That's a fair question.
Okay.
And we can actually do this one.
Yeah, I'd love to do. Sure.
Very often, depends on, like how the hospital works. Sometimes they will have you put these parameters in and then separately do what the max is. And the max is going to be based on what these numbers are. Okay, so if you're asked, if you're given a set of PCA parameters and you're asked, well, what's the maximum amount that this patient produces in a 24-hour period? Well, basal is what, 24 hours a day? 0.5 milligrams. So if they got 0 bolus doses, the most they can get in, or really the amount they would get is 12 milligrams. But we know that they're able to bolus themselves 1 milligram every 6 minutes. Now, again, theoretically, the maximum they can get, we typically talk about 4-hour max, not a 24-hour max, but just to entertain the possibility, we'll talk about a 24-hour max patient, assuming they're up overnight and they are bolusing literally every 6 minutes. How many boluses would they get in an hour?
10.
Doing it every 6 minutes, it ends up being how many an hour?
10.
10. Bolus is an hour times 1 milligram. How many hours? Is it? That ends up being 240. So we found, I have to get there, but that is theoretically.
252?
24-hour day. Every 6
Right?
minutes.
Yeah. That's gonna be the question.
But,
252, but yeah.
oops,
There's the calculator.
that's embarrassing. That's why it's exactly. It ends up being individualized. You may, like, if you're starting at PCA, you may very well be what you presented, the other way around. As they remain on it and you get a sense of what their use pattern is, you may decide to keep the bolus slow and increase their demand dosing, or you may, what's actually more frequently done, increase the bolus dosing and see if the demand will slow down. Again, this is just an illustrative example. I've seen it this way, I've seen it often the other way. And really the idea here is to get a sense of the use of this, hopefully. Any other questions on the opioids or intervention stuff? I do want to just kind of quickly run through the key things around oncology. These are the learning objectives. For objective one, anti-therapy for the purpose of cure for engagement of life. These are the things that you need to know. And there's a couple of slides on this. To give them an example, one of these you should be able to identify the type of chemotherapy that's being given. Okay. A lot of these other objectives, 2, 5, really base, actually 2, 3, 5, really more kind of the underlying pharmacology mechanism of action practices. Specific chemotherapy drug classes. Again, we're focusing here on drug classes, not individual drugs, except for a handful of individual drugs we're talking about that may have some toxicity or very widely used. For cytotoxic agents, again, they pretty much cause a lot of the same nausea, vomiting, a lot of issues. There are a few that have kind of toxicities I'll touch about. Targeted chemotherapy, I got a question from one of the students on this. I think it's fair to ask about certain of the targeted chemotherapies, for example, hormonal treatments, or maybe even some of the tyrosine kinase inhibitors that target very specific things on tumor markers on cancer cells. But generally speaking, I'm not going to be asking what is this therapy. We're discussing the drugs and talked about their various indications, but by and large, for the cytotoxic agents, some selection that you will carry on. Except to about educate patients. So again, these are the types of therapy. And I do want to very, very quickly just make sure that we can have this. These are for the last objective, I think. Number 6. Chemotherapy-induced toxicities. So tumor lysis syndrome, very quickly, that is a byproduct of the breakdown of cancer cells. You get potassium leaking into the bloodstream and urates and various other byproducts of DNA and protein breakdown. So their urethral agents, drugs that clear excess uric acid, obviously hydration, something, and we may then have to go to address things like elevated potassium, those are issues. Hemorrhagic cystitis. You know that this side effect is highlighted and the very specific side effect. So this is basically a
Can you repeat the drug that's given?
It is the drug that's implicated in cyclophosphamide. Drug that's given.
Thank you.
Myelosuppression.
Right.
Again, that's a broad toxicity from most cytotoxic therapy agents. Those drugs are sexy bone marrow. For anemia, what do we do for that? We can either transfuse, of course, but the colony stimulating factor here is epogen. Talk about that. Basically, that's an agent that helps the bone marrow spit out more red blood cells. The thing to remember about epogen is that it works in the setting of adequate iron stores. We'll talk about that. That's the message. So you need to have a good store of iron. That may involve iron, IV iron, or iron supplementation, and then giving it epogen to reduce the red blood cells. If it's white, red blood cells. If white blood cells are turned up, leukemia, then, the cognitive factors, the rest of them. Larger than vomiting. Various types. Anticipatory, is that? It walks into the, vision center and they get nauseous, right, before they even, introduce the drug or, even, puncture the vein or whatever. Okay, that's anticipatory measure. How do we treat that? Today's, class. Think of it as kind of just. Acute nausea vomiting. Think of the serotonin antagonists, Anticon. Those are, key agents, but also will use. Methazine. Then the delayed onset. Nausea vomiting. That is the days after. It will be worthwhile if you spend maybe 10 minutes going through that nausea vomiting. That's the best way. It's the best. And then finally, mucositis. What is that? Sloughing of the mucositis wall cavity. And there, contains
lidocaine,
lidocaine, lidocaine, it's suspension, you can switch it out, it's really soon. Can I talk a little bit about hypercalcemia as well? But those are the key chemotoxicities that really, it's a little bit more supportive here, as opposed to the actual hardcore. But, again, just having that familiarity with oncology drugs, again, just knowing the mechanisms to the point where you can expect it to the patients. Anyway, any other questions? All right, thank you.
Thank you.
I think we need to get.